Welcome to this presentation about methods to assess pain in nonverbal patients. I'm going to tell you about the types of patients who are typically the nonverbal patients who need this assessment and commonly used tools and scales for these pain assessments, and how important consistency is once you're using a pain assessment tool and how this affects improved pain management outcomes. These are the typical types of nonverbal patients that might be encountered. Infants, including premature babies and children, usually up to about 7 years of age. And then cognitive impairments, which can cover a wide range with dementias and mental deficits. In the hospital setting, patients may be nonverbal because of a serious illness. There could be intubation involved, postoperative status, and recovering from coma. This could be two categories of what we call the vegetative state and minimally conscious state. And then additionally, there might be some cultural or educational as well as language barriers that can impact the patient's ability to verbalize their pain. In a study by Schnackers et al., there was a comparison done between healthy patients, a minimally conscious state, which we call the MCS, and the vegetative state, the VS. As seen here, the areas in red in particular are the regions of the brain that were activated during a painful stimulation. In the study, they used a fingernail pressure. In the healthy patients group, you can clearly see the activations between the thalamus and the frontal lobe for these pain processing functions of the brain. In the vegetative state, there was so little that it was felt by repeated studies as well that there was not the connections in the brain to indicate these patients would be experiencing a conscious level of pain. And then with the minimally conscious state, there definitely was the connections. You can see the difference between the VS patients, the activation being similar to controls where we had with the healthy patients. The activation of the areas of the brain were seen with the painful stimulation. So that is considered that there is neural processing being done and a conscious pain perception in these minimally conscious state patients. Here are some typical pain scales and tools used for the very young patients, premature infants, newborns, and younger children. The FLAC scale has been in use for some time, and it's the faces, legs, activity, cry, and consolability, generally for ages 2 months to 7 years for those who cannot, who are considered pre-verbal or cannot report their pain. And because it is a 0 to 10 scale, it's easy to use and determine a likely threshold by the rating that you get. The second one shown, the premature infant pain profile, is a more complicated scale. The scale ranges 0 to 21, with a 12 as a threshold for some pain intervention. It's typical for premature infants and to assess pre and post procedural pain. The neonatal infant pain scale is again more focused to premature babies, and it is a 0 to 7 scale, with 3 being the threshold for a pain indications that might need a intervention. It is considered a very easy to use scale. Also, another scale called the comfort scale is a more involved scale, but it is used in intensive care units for children, and it observes the respiratory, motor responses, cardiac frequency, blood pressure, facial expressions, agitation, and level of awakening. It's a sole scale that has been used for assessing oversedation, comfort, and distress in these newborns to young children in an ICU setting. To be successful with pain assessments, the clinician needs to gather as much information as they can the patient's medical and surgical history, any information from caregivers and family about their normal behaviors, and things that may be unique to that patient. With the nonverbal pain scale, this has been used in ICU units, and there was a study from the American Journal of Critical Care showed when its use was implemented on a unit, their pain assessments went up with the consistency for the patients, and the nurses involved gained confidence that they reported in doing these assessments, because we do know that these are the most challenging type of assessments when the patient is nonverbal. Also, the behavioral pain scale, primarily for intubated adults, gives you some information to assess regarding the patient's facial expressions, any movements of the upper limbs, and their status with the mechanical ventilation. And an important scale to use for patients recovering from coma is this NCS, the Nociception Coma Scale. There typically hasn't been too many assessments geared toward these patients, and from the previous slide where we can see there still is quite a bit of brain activity that would indicate they're experiencing pain on a conscious level for this group, even though their assessments can be very inconsistent with what you see in responses to certain stimuli or their verbalizations. So with the NCS, what is being assessed is their observations with their motor responses, verbal responses, visual responses, and facial expressions. And these are rated from 0 to 3 for each of these 4 categories. And it can give you a really good idea of what they may be experiencing and a level of pain. And the last one I wanted to mention is the Pain Ad Scale. This has been used for some time in patients with varying levels of dementia, but especially the advanced dementia patients. It can include the 5 items of breathing, vocalizations, usually that would be some type of negative vocalization, facial expression, body movements, and consolability. Again, with the 0 to 2 for each of these, and a total of 10 would be the highest score then, which is a nice easy scale. The important thing is to find a tool that would be appropriate for the type of patient and the setting that you're dealing with, and to use it. Patient satisfaction with pain management in multiple studies has definitely increased when their pain is assessed and they're getting treatment. We want to avoid any adverse outcomes that can come from unmanaged pain. Patients may have minimal responses, but later their memory of this certainly can still be there, even if they couldn't express it. And then when clinicians are better educated and have the confidence and skills to use these types of assessments, documentation improves, and then that does improve with the patient outcomes as well. And to summarize, we talked about the types of patients who are the usual ones who are unable to verbalize their own pain, and the pain assessment tools and scales that we have for different types of patients, and the benefits of using a pain assessment tool in the first place for non-verbal patients. Thank you for viewing and listening to this presentation, and if you would please follow the link for the survey, I would really appreciate it. Thank you.